اهلا وسهلا بيكم. النهارده هنتكلم عن موضوع جميل خالص، ان هو احنا الكوفيد. حاضر. هنتكلم على موضوع فيري الموضوع الساعه زي ما احنا بنقول. اوكي. موضوع الساعه زي ما احنا بنقول الكوفيد 19. الكوفيد 19 طبعا الرعب اللي احنا شغالين فيه بقالنا حوالي 8 9 شهور او اكتر، وي دونت نو الا كان بتوع الصين اكتشفوه امتى، لكن الموضوع بقى واخد طبعا، ده من اهم امراض العصر، واعتقد دي اسوأ سنه. انا عملت سلايد شير. انا شيرنج دلوقتي سلايد شو. اوكي. انا لسه اصل انا هعمل اوكي. انت عايزني ريكورد سلايد شو؟ انا مش سامعك.
بلاي بس
ما انا لسه. انا لسه ما فتحتهاش. انا بس. انا عارف. انا لسه ما فتحتش. بس انا بتكلم الاول على الانترودكشن بتاع الموضوع. فالنهارده هنتكلم على موضوع مهم قوي، انه الموضوع الكوفيد وايه مفهوم الكوفيد. وانا هكلمكم على جيرني، اخدكم كده في رحله على بدايه الموضوع، ابتدى ازاي وابتدى نمشي فيه ازاي، وتوقعاتنا ليه ايه، واللي حصل فيه ايه ان بريف في بعض الاوقات، لان الموضوع كبير قوي. فانا حبيت بس اسلط لكم الصوره، وهبتدي برضو ادخل بحته البيدياتريك عشان المؤتمر كله نيوناتولوجي وبيدياتريك. فانا هحاول بريف كده امنشن كذا حاجه. طبعا ده من اكبر الريسيرش لاب اللي موجود، انا كنت بشتغل فيه، ولغايه دلوقتي انا ادجانكت معاهم في الديبارتمنت اوف سيرجري في الستيت يونيفرسيتي اوف نيويورك، اب ستيت ميديكال يونيفرسيتي، ودي اكبر جامعه حكوميه تقريبا في امريكا، او في نيويورك، لان احنا عندنا 64 جامعه ببعض. ف... فانا بتشرف ان انا بشتغل معاهم من حوالي 5 سنين تقريبا، 4 سنين تقريبا. وبنبتدي نتكلم انه ابتدى في 2011، سوري، فبراير 11 في 2020. ابتدت الدبليو اتش او قالت ان يا جماعه في بانديميك، بعد كلام كتير قوي ان في اتيبيكال نيمونيا حصلت في الصين في يوهان، وكانت الاول بيخبوا، وكان دكتور اسنان حتى هو اللي اتكلم عليها، وبعد كده هو حتى مات فيها، وما كناش عارفين ابتدت امتى ولا اتعملت امتى ولا كان الهوست ايه. ودي كانت ابتدينا نتكلم على في بانديميك، وسموها سارس، سيفير اكيوت ريسبيراتوري سيندروم. وانا هقول ايه الموضوع. وكانوا اتكلموا قالوا انه هو يا جماعه الموضوع ده بيبتدي الانس بتاع السيمتومز بتاعته within 7 days، وكان في بيحصل شورت سبريس على اليوم الثامن، والاي ار دي اس بتدخل على من 8 ل 14 يوم، والعيان بيدخل على ميكانيكال فنتيليشن من 7 to 14 days. دكتور اتس بيتر ان انا اتكلم عربي ولا انجليزي؟ في ناس انجليزي اتكلم انجلش. انا مش سامع.
لو انجلش يا فندم يبقى
Okay, we begin. Okay, this is great. It was a lot of reports about coronavirus in the beginning of China in 2019, in 2020, and the pandemic announcement from the WHO in February 2020 that there is a pandemic all over the world that affects many countries. So, and there is a lot of symptoms at this time, and we noticed these symptoms, and most of the papers came from China, but it was not accurate about this stuff. So the clinical presentation was at this time varies in symptoms from a wide range, from very mild symptoms or asymptomatic people to severe symptoms and fatal disease. And the people there, they announced that the acute respiratory distress syndrome, what we call ARDS, developed in 17 to 29% of hospitalized patients. And the secondary infection developed in 10%. But between 23 to 30 people of people hospitalized with COVID-19 infection having pneumonia and required intensive care for respiratory support. This is a preliminary data. 2 days ago, this is a picture of all over the world about what the case timeline. You know that the hot zone here, we are in US, they are having a lot of people having this disease, and the incidence was very high, and there's a lot of multifactorial effect of this. Egypt here, as you see, it's mild in everything, really. There is multifactorial also effect for this data, but it's not the time to discuss it at all. But as you see here, the country of distribution, number one is US, as we have about 21% all over the world, with about 8 million. This is from 2 days ago, this picture. This is about 8 million people affected. And India, number two, about 19 percentage point 8, and Brazil was about 13.5. And Egypt not documented here. This is great. So if we will see the Johns Hopkins up to date yesterday, this is US, 8 million, India, and this is the whole zone, as you see. And this data, this is the cumulative cases. As you see, US here, Egypt, just 1 dot here. And also here, this is a cumulative, and the global death, about 1 million patients. This is too much. In US, about 218. And this is by case fatality. Case fatality, it's we have too much in US here, and we have also some case fatality, about 5.8 percentage of the people. And this is also by incidence rate. It's increasing here, and Egypt, as you see, in small dots. There is a lot of multifactorial, as we said, because this can happen and must be investigated, by the way. Egypt here, the case is about 100,005, and the death is 6,000. This is great, and also the case fatality 5.8. In US, there is a lot of regions, a lot of cities below this a lot, but there is some regions is high still till now. And this is very important, the graph, and we will call that what's happening here, the death rate and the recovery rate. You know that the death rate decreased from February to October, as you said, and the rate of recovery rate is higher. It became higher. This is great, as we see what's going on all over the world. So yes, the disease have peak of death here in April. Yes, because we don't know from the beginning, the people don't know what's going on, what this disease, it's respiratory or cardiac or. This is the problem, and I think many people died in this area due to medical error also, because we have panic in the beginning that it's pneumonia, all the governments going to buy ventilators. They think that it's ARDS, typical ARDS, and we'll talk about it. And then the people dying from even ventilator, because as you know, the incidence or the prevalence of the incidence or the complications of ARDS, about 40 to 60% of people dying on ventilators. And in New York City, we reported 70 to 80% at this period when using the ventilator, especially with ARDSNet protocol, which is low tidal volume. And we'll discuss a little about this stuff because the lecture is too much. So here, considering the heterogeneity of the disease was not homogeneous all over the world. There is a lot of symptoms, a lot of complication. We don't know it. And we reviewed what's going on. When we reviewed, we must understand what the pathophysiology. If you want to treat any disease, you want to know what the cause of this disease, this disease happened. Especially, there's a lot of conflict about the pathophysiology of this disease in the beginning. And now I think we know a lot about it. So the deterioration with pathophysiological aspect due to hyperinflammation and platelet activation, endothelial dysfunction is very important, and the coagulopathies happened. So yes, sometimes it happened that ARDS typical with this disease, but most of the time it's due to other multi-system or multi-organ affection. As we know that the patient with severe critical disease complication like ARDS, septic shock, thromboembolism, and multiple organ failure, what's called MODS or MOF, including acute cardiac and kidney injury. So it was not the lung only. Now, however, less information is available about the rate of complication, and this is a problem of non-hospitalized patients because the problem came mostly, you know that about 80% of people admitted of COVID-19 resolved without any intervention. But 18% or about 20% admitted to hospital and about 5% admitted to ICU. And from those people, 46% will die from there. So they think that it's ARDS. So according to the ARDS, we know the pathology, platelet activation, clot formation, and we begin, as we say, with serious systemic inflammatory response syndrome, that the COVID-19 attached to SE2 receptors in many systems in your body, not the lung. So we consider the lung, and the lung will cause ARDS, acute lung injury, and acute lung injury will proceed to do the ARDS. So we begin to think that it's all of this pathology. Yes, it may be, as we think before, that it will cause all of this stuff, and finally it will end in ARDS. This is our thinking in the beginning. Then, as you know, the ARDS, it's something what we call VQ mismatch, but mostly alveolar due to acute lung injury, which will cause acute pulmonary edema due to disruption of this membrane and this alveoli, which is the most important part for gas exchange, will be affected. This is normal ARDS. But what's happening here, as you said, what's the difference between ARDS in normal viruses and in COVID-19 viruses? The problem, as we said, even my opinion is the definition of SARS is wrong, because SARS means severe acute respiratory syndrome. It's not a respiratory disease mainly. It's a respiratory with vasculitis. And this is the difference of our understanding of COVID-19. Because COVID-19, if it's ARDS, it will affect only this area. And then the VQ mismatch will happen due to the V part, ventilation part, not blood flow, because you need blood flow to go to your alveoli to get change, to get rid of CO2 and to take the O2 to your bloodstream. What happening here, if you have M+ here in this coronary and in this pulmonary artery or pulmonary arterioles or the capillary around the alveoli. So there is no blood flow to the alveoli. So the VQ mismatch will not be due to V, ventilation, it will be due to Q, which is the flow of blood will be decreased. From this time, nobody understands this stuff. So, and in the beginning, and they begin to give ventilators. And ventilators sometimes harm the patients, because if you will go to put the ventilation, the ventilators, you are correcting the ventilation part, the V part, not correcting the Q part. So we begin, Italian people, they begin to discover that what's going on, guys, it's not a ventilator, it's not a V part, it's a Q part, especially when they analyze that there is clots, a lot of clots in the pulmonary artery of those patients after death. So we begin to understand more. So it's not a pulmonary only. So the definition, from my point of view, as I told you, was little wrong. And we can diagnose it, by the way. We can diagnose. We published one paper. It's very important. I want you to review it in American Journal of Respiratory and Critical Care Medicine, which is #1 all over the world. If you search my name, you will find it. By detecting the ATCO2, when we find that more ATCO2, it means good blood flow. When the ATCO2 decreased, it means that the blood flow decreased, and you can diagnose very easily. So we begin to say, yes, great. At this time, this was the alveoli, normal. This is your alveoli. By the way, we did it in our department in surgery, department in upstate medical university, and we by microscope, and we have this video from the microscope. This is the normal alveoli, okay, and this is the ARDS alveoli. As you see, there is movement, and there is no heterogeneity, homogeneity, open alveoli, open lung, and this is what happened with ARDS. So, according to what happened in the beginning, the people began to use ARDSNet in the ventilator. And you know ARDSNet is low tidal volume. And the low tidal volume since ARDSNet 2020, in 2000, the same mortality, 40 to 60%, with the best state-of-art practice. And they repeated from 2000 to 2020 without any changes. And as Einstein said, insanity doing the same things over and over again and expecting different results. And they begin to do that like this. And the mortality rate was in New York was about 70%. So in our practice there, we have group and we create something called time-controlled adaptive ventilation. And we tried a lot, and there is a lot of pioneer. And I think Nader Habashi, with the godfather of this mood, he came to you before in Port Said and gave some lecture about it. And this is what's happening here if we give the conventional mechanical ventilation in ARDS. You look to the alveoli, it's not opened. And when we give TCAV, and we get it by microscope, you will see what's going on in your alveoli. It's opened. And our target is open the lung and keep it open. And this is a lot of, and it needs a lot of lectures about this stuff. But this is what's happening. Even we get it by microscope again. This is the mechanical, this is a conventional mechanical ventilation. And this is the TCAV. You look at what's happening to the alveoli. It's open and the gas exchange became great and the patient improved. So now we think that it was, but instead of all of this stuff, the patient dying, still COVID-19 dying. So we think what's going on? So as we know, in most cases of COVID-19, the simulated immune system was capable of any resolving of some infections. But the problem here was dysregulation of the inflammatory response. And also followed by recruiting macrophage and monocytes and release of cytokines and the prime adaptive T and B cells in immune response. Cytokines this is the most common name we heard about it in the last many months. Cytokines storm, or hyper responsive syndrome of inflammation of our cells, because as we said, the coronavirus attached to the AC2 receptors on the wall of your alveolar wall or many organs. It's AC2 receptors found in the heart and most of the vascular tissue. So it affects many organs. And then the dysregulation of this inflammatory, and then your inflammatory response. If your inflammatory response is higher, what we call dysregulation of inflammatory immune response, will associate with many what we call SIRI, systemic inflammatory response syndrome, and would affect what we call MODS, multiple organ disease is what happened, because your inflammation will attack your organs, and it will cause a lot of multi-organ damage at the end. And this happened with sepsis, with ARDS, but now in COVID-19, we found this a lot, and we found other associating stuff with them. So the uncontrolled immune dysregulation with hypercytokainemia or macrophage activating syndrome is associated with ARDS, multiple organ failure, and mortality, which we observe it in the beginning. And also there is some autoimmune disease can affect also multi-system inflammatory syndrome in children. So there begin to publish a lot of pathogenesis about this stuff in COVID-19 and what we call endotheliitis. The propagation of severe COVID-19 was induced by vascular endotheliitis. And the endothelial layer is very important in our vessels, because endothelial layer, when you have a good endothelium, you will not have a lot of many diseases, because the beginning of coronary artery disease begin with the endothelial dysfunction. The beginning of most of the clots, endothelial dysfunction. So the endotheliitis happen by this virus, what we call RNA-induced thromboembolic manifestation due to local endotheliitis due to this group of RNA virus, including AIDS. It's not COVID-19. And it's reported in many cases, even in influenza do it, but it's very little. But in corona group, it happened, and in RNA virus, there is a lot of documented cases about it, even in MRSA, because you know the coronavirus beginning with SARS-1, which the mortality was about 9%, and it affected about 8,000. It began with China, from China, and also the host was bats. Then MRSA, Middle East corona also virus, that happened in Saudi Arabia, and mainly it was about 3,000 patients, and the mortality was about 39%. So it happened, the host-dependent cardiovascular factors or established cardiovascular disease, in addition to viral factors, could contribute to the severity of disease. If you begin, for this reason, if the people having diabetes is considered to be cardiac disease, by the way, hypertension, diabetes, superior myocardial injury or whatever, and on all you have chronic endothelial dysfunction, the COVID-19 will play a major important role in mortality. So endothelial cell involvement, still we are studying it. And we have, we found that endothelial function around the vascular beds of different organs can be affected and will decrease morbidity and mortality. And the histology, we found that there is presence of viral bodies within the endothelial cells itself and responsible for accumulation of inflammatory cells with evidence of inflammatory cell death. This is very important for all the people now. We are talking about COVID-19 endotheliitis in several organs. And this is what we call RNA-induced thromboembolic microangiopathies. And this is, we are now studying this. I'm lucky that I am principal investigator of two major IRPs researches, one in US here. We have about 800 patients, and other one in Egypt with Mansoura University. And we are studying about 280 patients on COVID-19 about this stuff, how COVID-19 will affect the endothelium and how it will affect arthritis or vasculitis. So the most important part with this is AC2 inhibitors, which is exposed and expressed in arterial and venous system, as you said. So ACT receptors available in arterial and venous system and play an anti-inflammatory and protective role. In severe critical case, bidirectional association between inflammation and coagulopathies. If you have severe inflammation, you will have severe coagulopathies. And this is what exists in most of the inflammatory status, acts as an important trigger of the coagulation, will promote the, and may promote an aggressive immune response. So we begin to observe that those people have macrovascular thrombosis. COVID-19 patients, the first manifestation will be acute heart attack, acute myocardial infarction, acute heart failure. We observe many patients with a cerebral vascular stroke. We preserve many of them with acute pulmonary embolism. We observe many of them with having even lower limb gangrene due to infarction or embolus. We observe a lot of mesenteric artery occlusion. We observe a lot of acute hepatic injury. We observe a lot of acute renal injury, and this is in COVID-19, it's very fast to develop acute kidney injury. So in the past, they think that it's vascular, it's venous. When the beginning, when the Italian people begin to analyze the bodies of the dead people, and they found that there's a lot of pulmonary blood. Then they said, "Oh wow, it's a venous system." Then we begin to discuss, my group, we began to discuss, no, it's not a venous. This is about 6 months ago. And this was my idea. I'm honored that it was my idea that if it's venous, it will go from your deep venous thrombosis or your deep veins, and it will go and stuck in your pulmonary artery. It will not pass to the right side, except if you have a right shunt, right to left shunt. So you must have ASD, VSD, or anything to direct the thrombus from the right side to the left side. And with Eisenmenger syndrome, also you have right pressure more than the left pressure to pass the thrombus from the right to left. And it's not available. It's not here in COVID-19. So what's going on? It's not a venous. Mostly it's arterial. So this was when I discussed this with Global Health here and the people here, they were very astonished and very excited. And we began to do this to prove it. So, and in JAMA 2 weeks ago, they proved it that the arterial and venous, arterial 11.1 and venous 6.1 double arterial. And instead of, they didn't do a lot, 6.2 by history, by examination, not by Doppler, venous Doppler in the lower limb. So, and arterial thromboembolism may be predominate macrovascular complication in many patients. So I think if you have cerebral vascular stroke, this is arterial. Cardiac injury, arterial. And we'll discuss about this. So we begin to say SARS, it's pulmonary. No, or it's definite. From my point of view, from my opinion, it's wrong. Why? Because we have a lot of acute cardiac injury not related to that. Maybe ARDS can affect, but it's not the main pathophysiology. So we face a lot of problems. Now the people at home all over the world, they isolate themselves 14 days and nobody gives them any medication. And all the medication you are taking in the outpatient is not evidence-based. I know there is no evidence-based till now in COVID-19, but there is no research supporting anything. What are you taking in outpatient? Vitamin C, vitamin D, zinc, a lot of things. This is debates about this stuff. And every country put their guidelines, I don't know, without any evidence. So it's a mess, these guidelines these days, all over the world, by the way. In US, they are not giving anything to the patients, except Tylenol when he has symptoms. But also, we don't have any parameters in outpatients. The people getting COVID, they went to home. We don't have any parameter. We don't have EKG. We don't have D-dimer. We don't have any blood test. We don't have, because number one, the patient at home, there is no space for them in hospital, number one. Number two, the healthcare provider, even in some countries, they are scared to contact them. So there is no EKG. And at the beginning, they were taking hydroxychloroquine, Deslomax, a lot of things. And they said, this is a bag of care or something like this. I heard about it. This is insane, because what's happening in some countries, like Brazil, they give hydroxychloroquine and Deslomax, a lot of stuff, and without EKGs, without ECGs. So, and the prolonged QT interval, and the people dying from Torsades point. And this was the beginning of this dilemma in outpatients. And this is now we want to understand what's going on of those patients from the beginning to the end. So lack of universal guidelines in early detection and treatment of COVID-19 associated coagulopathies in non-hospitalized. I published one paper also, if you reviewed 2 months ago, about multiple thrombotic events in patients coming from their home to the hospital in COVID-19. Because the people can die at home, can have thrombose at home, because we don't know what's going on with these people. So we begin. We want to talk about, it's COVID, it's cardiovascular disease, what's cardiac manifestation. This is the title of our lecture, cardiac manifestation of COVID-19. As we know that it's infectious disease and has some significant implication of the cardiovascular care, and we observe a lot of complication from the cardiac. First, those will infected with COVID-19 and have pre-existing cardiovascular disease have increased risk of severe disease and death. Great. For this reason, or any patient which has comorbidities and cardiovascular disease, we take care of it. Second, infection also can be associated with multiple direct and indirect cardiovascular complications, including acute myocardial injury. And this is very observed, and I'll talk about it now. My acute myocardial injury, we will not say myocardial infarction. We call acute myocardial infarction because the virus can affect the ACE2 inhibitors, which is available in your myocardium, or it will come to the vascular through your coronary artery. It will affect your coronary artery. So two ways. The virus can affect your coronary arteries and do local endotheliitis and infarction without diffused vascular disease like coronary artery disease. Because if you have dyslipidemia, diabetes, and hypertension, all of these coronary factors will affect your endothelium and will do diffuse. If you get PC, if you do coronary angio, you will see that your coronary angio diffused injury. But here you have local injury in COVID-19. Local endothelitis, and it will collect some thrombus, and the thrombus will go to occlude your coronary artery. This is number one. Or the coronary artery can also join with the ACE2 receptors at your myocardium, and it will cause myocarditis. And also, if you have myocarditis, you have prone to develop a lot of arrhythmias, supraventricular and ventricular, and we observe a lot of it. And also, you have venous thromboembolism beside this stuff. And third, if you take therapies, and we have a lot of failed therapy in COVID-19 or under investigation, they may have also cardiovascular effect, like hydroxychloroquine, desmomycin, even remdesivir, a lot of things, and drug of interaction. There's a lot of them, and they are not studied well, but we are giving a lot of things to save life because we don't know. The vague things is we have panic. You will have panic if you are dealing with vague disease, and COVID-19 is a vague disease in the beginning. Fourth, the rapid triage of patients with cardiovascular disease, we must do this stuff. And also the healthcare provider was very vulnerable. And you have a lot of doctors dying and nurses dying in Egypt in the beginning of this stuff because they are exposing to a lot of viruses and they don't know. So what we call acute myocardial injury is a common phenomenon in patients with COVID-19, which is a key evidence of COVID-19 infection and affect the heart. The prevalence is great. It's about 20% in what I report on 416 hospitalized patients. So it's too much. And they said that the recent meta-analysis published in recently, about 8% of patients with COVID-19 exposed to acute myocardial injury. And the rate is roughly 13-fold higher in patients. So about 90% in severe disease having this 90 plus have this acute cardiac injury in intensive care comparing to patients with severe disease. This is too much. So it's not a respiratory disease. It's mostly cardiac disease. So as we said, the potential mechanism of myocardial injury at this time was based in acute myocardial infarction. Some cardiologists, you will see acute myocardial infarction. It's not pure MI. It comes suddenly or myocarditis, inflammatory response, acute heart failure. The patient can present with acute heart failure, and we'll discuss some of them now. Hypoxemia also can cause type 2 myocardial infarction. Pulmonary embolism also can cause, and even stress cardiomyopathy. This is very common, and this condition can exist in the same patients. All of this can happen with the same patients, or one of them. And this is what we call, this is a broken heart syndrome, as we said, what we call Takotsubo syndrome. This is from the Japanese part. It's broken heart, enlarged ventricle due to a lot of norepinephrine happened due to stress, and this is what happened in grief and panic in COVID-19. We observed many cases in the US having this stuff due to COVID-19. So it was various pathophysiology mechanisms. What's happening here, and with regard of myocardial injury, direct viral invasion of the heart, or similar to pulmonary infection. So you have infection in the pulmonary, you have infection in the heart, myocarditis, and now we are doing some research. We have some cardiac tissue from some animals, and I was collected a long time, and it's time to work on it now to see what's the effect of COVID-19 or sepsis on the cardiac tissue. So direct viral infection can occur or through vascular effect. This is what JAMA published in two. Also, we have a lot of pathophysiology can cause this. And also, SIRI, the systemic inflammatory response syndrome can cause it. And you know, I will tell you something. In sepsis, we have sepsis, we have in our ARDS, we have systemic inflammatory response syndrome. And this inflammation, cytokine, will go to attack your organs. Okay, and it can cause hyper or hypocoagulable state in sepsis. In COVID-19, most of the cases, hypercoagulable state. So we found a lot of thrombus in many organs. So, and this will happen also, coronary atherosclerosis, the people already have atherosclerotic plaque. We found that the virus can make this plaque rupture and cause cardiac impairment. So there is a lot of effect of this virus in many things. A large proportion of cardiac injury also attributed to type 1 and type 2 myocardial infarction, defined as thrombosis caused by plaque rupture, which is type 1, and or type 2, which is imbalance between the myocardial oxygen supply and demands. And this is what's happening. You will find troponin T. This is what we observed in this stuff. Troponin T has very important, it's a very important parameter to estimate the mortality or morbidity in COVID-19. Because if you have high troponin T, you will have more mortality and morbidity. If you have normal troponin T, we observe that it's great. It's a good not decrease mortality and morbidity. And this is what we call type 1. You have atheromatous plaques here, and you have here, there is no normal coronary artery, what's called the coronary stable or normal coronary artery MI. So this acute cardiac injury can be combined with inflammation, as we said, and comorbidities, and the cardiovascular adverse effect, also various drugs cannot be ignored. So also you mentioned the inflammation, the progress of this inflammation can affect also what we call multi-system inflammatory syndrome in children, MESC, or we can call it pediatric inflammatory syndrome, temporarily associated with SARS, what we call BEMS-TS. It's a pediatric inflammatory multisystem syndrome, new dangerous childhood, because we think in the beginning that the kids is not prone to severe complications. And most of the people was not scared about the children. And they have a lot of explanation that the distribution of ACE2 receptors may be in the upper part more than the lower respiratory infection, and the COVID-19 will make some upper respiratory infection not going to lower because the kids don't have a lot, or their immune system is not mature yet to have this stuff. There's a lot of things or they exposed to a lot of coronavirus before during their lives. There is a lot of explanation about the kids. But in England, from on July, they begin to observe about 80 child have these symptoms. So what's going on? And there is some, I will give you some data about it. And there is one a review article about this stuff. It's recently published. It's say that, as we said, in early May investigation there in UK, and this is the first cases reported, about 80 severely ill pediatric patients presenting with hyperinflammatory shock syndrome with multiple organ involvement. Children manifested, as we said, with Kawasaki-like syndrome. Okay. Complete or incomplete, rash, high fever, conjunctivitis, peripheral edema, and GIT symptoms. And this is one of the very important paper. I want you to review it. It's very important about systematic review about many clinical trials happen regarding to this. And it's about multi-system, what they found a lot of very nice, this is a clinical sign and symptoms, mostly, as we say, fever 100% of people, about 600 child, 662 100% of them was having fever, myalgia, and then followed by abdominal pain and diarrhea, 73. Vomiting was very important, also symptoms coming here. Conjunctivitis, 51%, and rash was 56%. So if you have baby with rash or a child with rash, please consider these symptoms as to do COVID-19. As we said, mostly we said that any abnormal from your normal, any abnormal symptoms or manifestation from your normal, you must do COVID-19 test. But this is very important to take care about the kids. And we found a lot of data from them about inflammatory markers, about many of them with having a C-reactive protein would be higher in about 439 of 660. And the ferritin will also be higher. There is a lot of YPCs will be higher, and there is a lot of D-dimer also. D-dimer is not significant because it will happen in a lot of things, but D-dimer, one of the good parameters. Also, we have here a very important parameter. I don't know you use it or not, thromboelastogram. People working in ICU, even in pediatric, we use this. Is very important. Even the doctors here in US, they are not using it. It's a very good parameter to see that the patient will have thrombotic changes or not for hyper or hypocoagulability. And even the doctor at ICU, when I talked to them at the beginning, and that we discussed it because we use this parameter very important in ECMO. When you use ECMO, extracorporeal membranous oxygenation to save life. So before you give heparin or give anticoagulant, it's very important to know this thromboembolic thromboelastogram, TEG. So, and he found a lot of good data about this stuff. How many diarrhea of those patients? This other study about 58 patients, and they found how many abdominal pain, 31, about 53%, 52 diarrhea, rash also, shock. They came with shock and vomiting for 45%. There is a lot of these symptoms of those patients. You will find, and they used a lot. They have acute cardiac kidney injury. About 22% of them, 47% of them used inotropics and ECMO. This is what I told you about 5 of them. And in the beginning, ECMO was not working well, but now ECMO is working very well, especially when we add cytosorb. Cytosorb is a chemical substances to filter the cytokines. We put it with the ECMO to filter all your blood and to absorb the cytokines, then it returns back to your blood without this cytokine, with little cytokines, so it will decrease the inflammatory response of this disease. And I know the CEO of this company, we are doing some research now with them. So the respiratory also, 43% of them, they exposed to intubation, intravenous. They treat them with immunoglobulins, 71% of those people getting anticorticosteroids and anti-IL-6 antagonist. This is anti from IL-6, one of the parameters also of the inflammation. We measure it in COVID-19. Then we reviewed and summarized clinical presentation of new children that most linked to COVID-19. Mask is very dangerous disease. This is what the recommendation at the end of the review. They have a lot of limitation of this review. It's retrospective review of them. So it was not, it's great that this result came, but they said that a multisystem inflammatory syndrome in children is dangerous disease infection characterized by extreme inflammation, fever, abdominal pain, conjunctivitis, and rash. And children will typically show signs and symptoms of 3 to 4 weeks after COVID-19 infection. They found that most of them has about 80%, I think, have COVID-19 positive antibodies. But you know that antibodies, because it's after 4 weeks, sometimes the PCR is disappeared. So the antibodies will be available, about 80% of them, but there is some of them will not found it like this. And many will progress rapidly into shock and cardiorespiratory failure. Families should seek immediate medical care in children with this condition, decompensate quickly, and most children will need management in an intensive care. Overall, children will survive this hyperinflammatory conditions with, as mentioned, of immunoglobulins, steroids, and multidisciplinary team of healthcare providers, and in some cases, immunomodulatory agents. And also, MESC is rare, but potential long-term sequel for this disease are currently unknown, because we observe a lot. There is one paper published yesterday about some athletes have this inflammation of their myocardium and persist with them long time. And some of them progress to sudden cardiac death. We have 2 patients, I think, we reported here that they, after 3 to 4 months, they died because the people have myocarditis, the inflammation process is still, and they discharged from the hospital without any echo, without any follow-up with MRI or something like this. So our conclusion, as the understanding of acute myocardial injury are varied in patients with COVID-19, comprehensive cardiovascular examination after balancing the risk of infection and crucial for differential diagnosis and precise treatment. In addition to acute myocardial injury, as a large number of patients are discharged long-term, this is very important to all the cardiologists. We must follow those patients by echo or by MRI, whatever, according to their complaints, in long-term, and we require further follow-up. And at the same time, this is my opinion. It's not, we are studying this, and I published these sentences in 2 papers now, that, and there is evidence that during pandemic, low-dose aspirin is used effectively in secondary prevention of cardiovascular disease, prevention of venous thromboembolism after total hip or knee replacement already used, and also in treatment of multisystem inflammatory disease syndrome. But there is debate about the use of low-dose aspirin or not. We're still studying about 1,000 patients, and I hope that we collect the data already, and I hope that I will give you the results as soon as possible. And maybe if we get these results, we'll change the guidelines all over the world about using of this aspirin or not, if we have good results about this stuff. That because it's arterial disease, our concept is why we will give anticoagulant if it's arterial, why we're not giving aspirin. And many people use it, but there is no evidence base, as I told you. And I'm not recommending to advise you to give anything because there is no evidence base. But we're still studying, and especially the low-dose aspirin has great, it's anti-inflammatory, anticoagulant, antiplatelet, and also antiviral. So we are searching for who's the people who will give if we succeed that we have good results from aspirin. But till now, there's a lot of debate about the usage of low-dose aspirin for primary prevention and arterial thromboembolic manifestations for COVID-19 patients 40 to 70 years old who are at high risk of coronary vascular disease or cardiovascular disease, and such as the family history and premature cardiovascular disease with low risk of bleeding. Because if you give it to all the people, you will have a lot of bleeding, especially aspirin doing silent melena. Take care of this stuff. If a lot of people have aspirin and they have melena and they don't know. So aspirin protective rule in COVID-19 associated with ALI, acute lung injury, yes. Also, they proved that there is some cases in 2 studies, around 2 studies, aspirin has good results with ALI. Vascular thrombosis without previous coronary vascular disease, and mortality need further investigation to establish that. We need further investigation, but pre-hospital, this is the problem. Administration of aspirin might have a role in preventing COVID-19 complication, especially in arterial thromboembolism and both hospitalized and non-hospitalized patients. Thank you very much. It's a lot of information in this stuff, but as I told you, I'm trying to do my best to deliver. I'm working in this field